Hi, everyone. Welcome to this webinar, Slow Release Oral Morphine and OAT, Evolving Options for Opioid Use Disorder. I'm Kathy Tam, the Director of Professional Programs and Education at the Ontario Pharmacists Association. I want to acknowledge that this webinar was possible with funding from the Mental Health and Addiction Centre of Excellence from Ontario Health. Uh, with Ontario Health, they provide funding to OPA to help provide other resources related to opioid use disorder and mental health and addictions. So I wanted to share some of that here. I can put some of these links in the chat so you have access to them later. But we do have a discussion forum. We do have modules on addictions and opioid agonist therapy that is free, and you can sign up on the link there. And we have a number of different webinars and resources available there. We do have a drug information support email where if you have any questions around mental health and addiction, specifically around OAT and methadone treatment, you can email that email there. We have information on naloxone. We also have a methadone and buprenorphine toolkit. Today, I want to welcome Aviral and Ivana, both pharmacists at the Hamilton Health Sciences. Aviral is a pharmacist with over 7 years of experience in various community and hospital roles. Passionate about improving outcomes in opioid use disorder, he has developed a special interest in opioid agonist therapy, particularly the clinical application of slow-release oral morphine. Avira brings a patient-centered approach to practice and is committed to advancing evidence-based care. He currently supports interdisciplinary teams at Hamilton Health Sciences in optimizing OAT delivery across various healthcare environments. And Ivana Jankovic is a clinical pharmacist at Hamilton Health Sciences. She completed a bachelor's of pharmacy at Dalhousie University in 2005, followed by a doctor of pharmacy in 2015 at the University of Florida. In her roles in internal medicine, acquired and traumatic brain injury rehab, and now spinal cord rehab program, Ivana is a clinical expert in the management of patients with opioid use disorders. Her role includes optimizing patients' treatment plans and providing patient and family education to ensure understanding and engagement in follow-up plans to improve patient outcomes and reduce hospital readmissions. Welcome, Ivana and Aviro. And just give me a second. I'm going to bring up your slides here.
And as they come up, I just wanted to thank you, Kathy, for the introductions, as well as for inviting us to present on this important topic today. I also wanted to welcome our audience, our colleagues who are joining us as well.
And here we go. Do you see the slides?
Yes, I do. So today we will be discussing slow-release oral morphine in opioid agonist treatment as an evolving option for opioid use disorder. In terms of our disclosures, both Averil and I do not have any past or current relationship with commercial entities, but of note, we have received an honorarium from OPA for this learning activity. Our learning objectives are to provide you with information that will enhance your understanding of the evidence for the use of slow-release oral morphine in opioid agonist treatment, as well as to discuss the role of estrom in management of opioid use disorders. We will apply recommendations from the latest established guidelines on dosing initiation, conversions from other types of OAT, as well as some practical points such as managing missed doses and providing take-home doses. And lastly, discuss pharmacy considerations, including prescriptions, community pharmacy dispensing, and challenges we see in the inpatient settings. So before we go on and discuss the management of OUD, just wanted to define OUD itself. As per KMH, it is a chronic relapsing illness, and it's truly associated with a very problematic pattern where the patient has moments of remission and moments of relapse. And it could be triggers such as a traumatic life event or a change in the economic stability, relationship issues that cause the patient to relapse, resulting in significant impairment or distress. It is a condition that often dominates the person's thoughts, feelings, as well as activities that they are involved in. And some of the key features include cravings, so an overwhelming urge to use the opioid. Over time, the patient develops an increased tolerance and can experience withdrawal symptoms. Certainly, if they abruptly stop the use of the opioid or reduce the dose of, and even though they're aware of the harm, they continue use despite negative consequences such as problems at work, school, home, as well as impact on social and health-related issues that can result. Next slide. So as we go through the presentation, we just wanted to introduce a case that you can keep in mind, and later on we will come back to Jason and discuss how to best manage him. So Jason is a 34-year-old male. He has a history of daily illicit use of fentanyl, so about 1 to 2 grams of fentanyl intranasally daily. He has had an overdose about 2 months ago for which naloxone was administered. His past medical history is significant for hepatitis C, but otherwise his vitals and labs are stable. He has tried methadone, but reported being quite diaphoretic and nauseated from methadone. He has also tried buprenorphine naloxone. Going forward, I'll refer to it as Suboxone, but reported more cravings coming on. So in the past few years, we have seen quite a sharp increase in opioid overdoses and related hospitalizations and death from the unregulated drug supply. In 2024, in Canada alone, we saw about 20 deaths per day due to opioid overdoses, as well as 67 presentations to ER and just under 100 EMS calls. 84% of deaths related to opioid overdoses was due to the unregulated drug supply, and three-fourths of those were specifically due to fentanyl. Notably as well, not everyone that tries Suboxone or methadone finds it suitable or effective. And one of the barriers is that patients find that the access to OAT is not rapid enough. It's not always available in all the towns or rural areas across Canada. As well, patients have voiced frustrations with approaches to methadone prescribing that reinforce the stigma. And so what the patient really brings forth often is that failure to meet their self-identified needs that is contributing to a significant number of relapses and deaths. And this truly flags the need for alternative treatment options to improve access while also better addressing the evolving needs of our patients with OUD, optimizing treatment outcomes in this population so that we see a greater engagement as well as better retention rates. In terms of the historical approach, in the past we've used Suboxone and methadone, and Nestrom was really considered as last resort or third line agent. It was often perceived to be a specialized led approach, and some of the barriers to using Nestrom were limited high quality evidence, concern over adverse events, and safety over other OATs. Because of its slow release, there is a requirement for prolonged observed dosing with Estrom. And lastly, difficulty differentiating prescribed morphine from heroin on urine drug tests. So if we look at how the guidelines have been set out, CRISM guidelines back in 2018 suggested or recommended that Suboxone is first-line therapy over methadone. Methadone was considered as second-line agent for patients who found Suboxone ineffective or as first-line in patients in whom use of Suboxone was contraindicated. And lastly, Estrom was really reserved for patients who found both OATs, Suboxone or methadone, ineffective or had intolerable side effects. CAMH then in 2021 similarly recommended Suboxone over methadone and suggested Estrom only in patients who did not find either of the two options again as effective, had contraindications to their use, or simply declined the use of methadone or Suboxone. But in the era of fentanyl overdoses, back in 2021, Medify came out with guidelines on treatment for people who use fentanyl, specific to methadone, and suggested this is the first time that we see a bit of a switch where they recommend the use of Suboxone and methadone both as first-line agents. Then, as the presence of fentanyl and highly synthetic opioids, as well as other contaminants, continue to rise on the streets and drive the number of hospitalizations and deaths, as well as clinical evidence that showed that some of the patients who used fentanyl had a very high opioid tolerance, one that was higher than patients using heroin or pharmaceutical opioids. The BC guidelines did a bit of a review and an update, and here they suggested that all OAT options, all three, be equally treated, with the prescriber taking into consideration disadvantages and advantages of all three options, and also having a really patient-centered approach. So a conversation with the patient in terms of what their goals are, what their circumstances are, what their past experiences have been with the OATs they may have tried in the past, and taking all of those factors into consideration to determine what the most suitable option for that patient is. And then lastly, in 2023, Medify guidelines came out with the recommendations on the use of estrom in OAT, and that is what we will be discussing for the most part today. So in terms of evidence for estrom, we only have 5 systematic reviews. Much of the evidence that we have is limited by its quality, not a lot of high quality study. Limitations including the design being open label crossover studies, very small samples, short duration of follow-up. So we're talking about 6 to 7 weeks and up to 6 months for a number of the trials that we have available. But there are some aspects of care that have been closely studied and that we can make some conclusions about. And these include treatment retention, satisfaction, substance use, and mental health. And I will go over each component individually. So with respect to treatment retention, we have a Cochrane review that showed similar retention rates to methadone and buprenorphine, naloxone, so about 80%. And the same results were duplicated in 2 meta-analyses that also found no difference in treatment retention between estrom and methadone. The one particular prospective study that had a pretty good enrollment rate of about 4,700 patients conducted in Austria looked at the 2-year retention rate, and it was the highest with estrom, so 71% versus methadone 47%, and then Suboxone 48%. And lastly, in a prospective German study, a 1-year retention rate for patients who voluntarily switched from estrom from methadone and Suboxone to estrom had a retention rate of 61%, which is a very good retention rate. When it comes to substance use, 2 different meta-analyses found no difference between estrom and methadone in heroin use or other substance use, such as cocaine, cannabis, methamphetamines. There was, however, a reduction in the injection drug use, so 50% reduction in injection drug use. Then looking at cravings and mental health, we have 2 crossover studies and a prospective trial, all of which found that study participants experienced a significant decrease in heroin cravings while taking estrom relative to methadone. Of note, all of these patients switched to estrom by choice, and these were self-reported decreases in cravings. Again, all to point out how important it is to include that patient experience when choosing the right treatment option for each individual patient. Compared with methadone as well, estrom had improved measures of anxiety, depression, and overall mental health. We do not have any studies that compared estrom to Suboxone, but we do, however, know that all OAT therapies resulted in improved overall mental health in patients who were on those therapies versus no treatment. Lastly, satisfaction was another aspect of care that was closely looked at, and patients reported reductions in side effects and higher treatment satisfaction scores. One of the limitations of those studies are that they were all open label crossover studies. When keying in on the side effects, those who were switched from methadone to estrom reported a significant improvement in constipation, nausea, sweating, and reduced libido. And notably, the patients also reported feeling quote unquote more normal. They were able to sleep better, they were more clear minded, and they were able to concentrate at work more than patients taking methadone. In a randomized crossover trial, participants taking Estrom reported also higher treatment satisfaction scores, with the majority of patients preferring Estrom over methadone. So 66% of patients preferred Estrom at the end of the 22-week phase, and then 83 at the end of the 25-week extension phase. So again, to reiterate, both the Medify and the British Columbia guidelines now recommend that Estrom can be considered as OAT option alongside methadone and Suboxone. So what about safety and adverse events? As I already pointed out, those were some of the factors that led to hesitancy to prescribe Estrom. In the past, again, keep in mind that just like methadone, Estrom is a full opioid agonist, hence we expect to see more side effects and a greater risk of overdose than with Suboxone. In one crossover study looking at Estrom and methadone, there were no differences found in adverse events. But methadone, however, does have potential to increase the QTC. So there is an improved safety profile seen with Estrom over methadone. So if you have a patient who's really responding well to that full agonist, but further dose titrations are limited by the QT effects, this makes Estrom an ideal option for that patient. In terms of drug-drug interactions, as you're all very well aware, methadone is involved in the CYP450 metabolism extensively. So a lot of drug-drug interactions. Those related to Estrom are specific to morphine glucuronidation. So we see an increased morphine exposure with benzodiazepines, tricyclics, ketoconazole, and nifedipine. And again, because of the hesitancy to prescribe Estrom, as it is a relatively new agent, and also because of that perception that it should be a specialized led approach, the guidelines were very specific to yet again outline who should really be indicated for Estrom. So patients who have severe OUD or are at high risk of opioid use, who have unacceptable side effects with other OATs, who have ongoing cravings or withdrawal symptoms. With other types of OATs, those who have contraindications to methadone, such as history of torsades, ventricular arrhythmias on or off methadone, and known or suspected QT prolongation syndrome. And lastly, patients with increased susceptibility to developing prolonged QT. So think about patients who are on multiple medications that have QT prolonging effects, patients who are presenting with endocarditis or are awaiting valve replacements, or who have presented with acute illness and have severe electrolyte imbalances. So in order to understand who really is a good candidate for Estrom, we do need to understand the molecule itself. So we're talking about a slow release morphine. It has no ceiling effect. It is a capsule that contains beads. Within each particular bead, so it's one type of a bead, there is the IR and the SR morphine inside. The bead itself has a coating that contains two different pores. And the capsule itself dissolves, once ingested, it dissolves in the GI fluid. And once it reaches the low pH acidic environment of the stomach, one of the pores, PEG, will release the IR formulation of morphine. And then as the bead gets down into the small and large bowel at the higher pH, so slightly alkaline environment, this is where the second pore releases the SR formulation, hence providing that constant therapeutic concentration of the drug over the 24 hours. So again, as a recommendation, it is Cadian and not MS-LON or MS-Contin that have been studied. We do not have any empiric studies on MS-LON or MS-Contin. This is not to say that it has not been used at times of drug shortages. So for anyone that may be interested, you can reference the Medify and the British Columbia guidelines on how to make that switch at times of shortages. Okay, and then so pharmacokinetics, the absorption, so the peak plasma levels are reached within 8.5 to 10 hours. There is a bit of a range because food will delay, but will not impact the extent of absorption. For those who are visual learners, I've included a graph from one of the trials. So the top line with the filled in circles are methadone, and then the bottom is morphine. Again, just reminding you that with methadone, the peak is reached within 2 to 4 hours, and that's basically when we're monitoring our patient for sedation or grogginess. But for morphine, it's more of a prolonged observation that is required because its peak is between 8 and 10 hours. In terms of metabolism, so estrom is metabolized by the liver to normorphine, morphine 3,6 glucuronide, and morphine 6 glucuronide, which is the active metabolite, and is then excreted via the kidneys. So if you have a patient with severe renal insufficiency, caution should be exercised. Start low, go slow, because morphine 6 glucuronide can have very potent analgesic and depressive effects. Elimination half-life is 11 to 13 hours, and for those who take estrom on a consistent basis, steady state is reached within 48 hours versus methadone, which is 3 to 5 days, meaning that we can titrate it much quicker than methadone. Okay, next slide. So in terms of absolute contraindications, so no surprise, hypersensitivity to morphine sulfate or any ingredient in the formulation. Anyone having any respiratory issues such as acute or severe respiratory depression, asthma with severe bronchospasm or severe COPD, anyone who has a non-functional GI because of that need to go from the acidic environment of the stomach into the more slightly alkaline large and small bowel in order to release both the IR and the SR formulations of the of Cadian. And lastly, use of monoamine oxidase inhibitors within the last 14 days, as it will increase both the effect of the opioid, but also increase the risk of serotonin syndrome. And then next is the relative contraindications. So anything that affects gastric emptying, certainly alcohol use. Alcohol itself will disrupt the SR formulation of Cadian and will essentially lead to a very rapid increase in the plasma concentration of the drug, and it has been fatal even in opioid tolerant patients. As mentioned earlier, it is metabolized by the liver. So if someone has a hepatic dysfunction, we expect to see a prolonged half-life and hence the risk of M6 glucuronide toxicity. And patients with higher risk for opioid toxicity, so patients such as geriatric patients, because their metabolism and excretion changes with age, those with severe COPD, sleep apnea, and those who are using other medications that can cause respiratory depressions, be it gabapentoids, alcohol, as I already mentioned. Caution in renal insufficiency, and I've just described that in the previous slide. And lastly, pregnancy with a question mark, and that's intentional, as I just wanted to get feedback from the audience in terms of what you may have seen in practice when it comes to use of estrom in the pregnant population. I will move on to say that as per the drug monograph, the use in pregnancy is contraindicated. It's contraindicated due to the risk of the withdrawal syndrome within the baby. However, this is a potential with any type of an opioid, be it a regulated or an unregulated supply. Hence, Medify guidelines and the British Columbia guidelines have removed that as a contraindication because in practice they are preferring to use patients who are already stabilized on estrom and become pregnant, they continue the use of SRAM throughout pregnancy and in the postpartum period. So I'll just read the comments in a bit, but thank you to all of you who have responded. And I'm just going to hand over the next slide to my co-presenter, Avril, so he can go over some of the other objectives of our presentation.
Everyone, my name's Aviral, and I'm here to continue the conversation around clinical and practical aspects of SROM or SROM. I've been told that SROM can also stand for spontaneous rupture of membranes in a pregnancy setting. Just a heads up, something to keep in mind. So in this context, SROM does mean slow release oral morphine. Having worked in both community and inpatient settings, I'm hoping I can help you navigate and put the clinical aspects into practice. I'm also mindful of our time here, so I'll try and keep it short. Um, so dosing goals. Shifting into the practical side, our three key goals with SROM are to manage withdrawal symptoms and cravings effectively over 24 hours, avoid sedation or overdose risk, and strike a safe, effective balance tailored to patients' individual needs. This requires thoughtful dose selection and regular assessment. Next slide, please. So considerations for starting dose. When initiating STROM, we need to consider opioid tolerance level, overall toxicity risk, and how reliable the patient's reported opioid history is. For example, someone using fentanyl daily may report using less than they actually are. If they have a very high tolerance from unregulated opioid use, combination of a STROM with methadone may be a safer option for stabilization, and one of these agents can eventually be tapered off. Next slide, please. So I have taken the liberty of drafting this slide for you folks. So this is how we categorize our patients from a tolerance and toxicity risk perspective, and this is very important because this is what we're going to use to initiate and stabilize them on strong therapy as well. So we have low tolerance, high risk patients. These might be some patients who are post withdrawal or using other sedatives. We have moderate tolerance and toxicity patients who might involve benzo or alcohol use. We have high tolerance patients who are actively using opioids, and we have very high tolerance patients with very low risk of toxicity because they are actively using drugs such as fentanyl or who have a very recent experience of high dose SROM therapy. Next slide, please. So looking at those toxicity and tolerance risk profiles, we also have the starting doses and titration, recommended titration doses for these profiles. So for example, for the low tolerance, high toxicity risk, we start low, go slow. So we start some anywhere between 30 to 50 milligrams of Cadian SROM, and we titrate by up to 50 milligrams every 2 days. On the other hand, for moderate tolerance, moderate toxicity, we start at 100 to 150 milligrams daily, and we titrate by 50 to 100 milligrams every 48 hours. For high tolerance, moderate toxicity, we start at 200 to 300 daily, and we titrate by 100 milligrams daily or 200 milligrams every 48 hours. And for patients who have extremely high tolerance due to drugs like fentanyl or other synthetic opioids, high potency synthetic opioids that they've been using through an unregulated supply, we start at 300 to 400 milligrams. Titration is the same as the previous risk profile. Next slide, please. So before we titrate, we obviously need an assessment criteria. Because of SROM's long-acting profile, we never increase the dose before 24 hours. Ideally, we evaluate before each change. In low-risk patients, we may pre-plan 1 or 2 increases if monitoring is in place. So when you see a prescription from a prescriber, you might actually see subsequently increasing doses over a couple days. So that is acceptable. These are low risk patients. So even if the clinician's not actively monitoring them in the clinic, it is acceptable if it's a low risk patient and the doses are low. So even without monitoring, those doses are going up. That's okay when you see that prescription. sedation, missed doses, and intoxication are red flags that should delay titration. So if you have a patient who comes to your practice in community, for example, who appears visibly sedated or intoxicated at that point, obviously, um, reaching out to the prescriber is warranted before we can continue with the titration process. In case if, for example, you had the patient coming in today with a higher dose than what they had yesterday, so that's when I'd be reaching out to the prescriber again. Next slide, please. This is a really key slide, and I like it because it says no upper dose limit. I also have that punchy graphic there just to kind of make it very evident. So when we see a prescription for such high doses of Cadian, obviously as a pharmacist, it does ring alarm bells, as it should. It's a high alert drug. So if you look at the data that Ivana mentioned before, so in literature, up to 1200 milligrams per day has been studied, and a mean of up to 800 milligrams per day is what was observed. However, doses of up to 2000 milligrams per day have been used in my own personal practice. I had a patient who was stable, very coherent, very okay, even at doses of up to 2800 milligrams of Cadian. So yes, so there is really no ceiling effect with this. Um, that said, every increase of the SROM dosing during your titration must be clinically justified and done with caution. Start low and recess frequently, especially once you reach the 800 milligram daily mark, because that's the average that has been used. So just because there is no ceiling effect, obviously increasing the dose is not the goal here. The goal is to manage withdrawal while keeping the therapy safe for the patient. So always keep that in mind. However, if you do see a prescription for a really high dose Cadian, it may be an acceptable order or prescription based on existing circumstances around the patient and their tolerance levels and their continued symptomatic withdrawal, which we'll talk about in a bit. Next slide, please. Combining with methadone. So for very high tolerance patients, you can co-initiate methadone and SROM. Start methadone at 30 milligrams and SROM at 100 to 200 milligrams. Then try, sorry, I got a comment if I can speak louder. Okay, I'll do my best. So combining with methadone for very high tolerance patients, you can co-initiate methadone and SROM. Start methadone at 30 milligrams and SROM at 100 to 200 milligrams. Then titrate SROM by 100 milligrams every 24 to 48 hours, as we had just seen in the toxicity tables. Once one agent stabilizes, the other can be tapered off if desired. Once the patient is stable on one of these, the other agent, methadone, for example, can be tapered off safely as long as it doesn't precipitate withdrawal. Next slide, please. So coming back to our Jason case, so let's revisit this patient. So if you remember, Jason is a 34-year-old man using 1 to 2 grams of fentanyl daily. He had an overdose about 2 months ago, requiring naloxone, and has previously unsuccessfully tried methadone and Suboxone. He had nausea and diaphoresis, excessive sweating from methadone, and experienced more cravings and increased unprescribed opiate use while he was trialing Suboxone. So my first polling question for our audience here is, what tolerance toxicity profile would you categorize him under? The second question would be, what OAT would you prefer? And the third question would be, what dose of SROM should we start for Jason? So the options are mentioned here. Please put your thoughts and opinions in, and then we can discuss.
Kathy here. I'll end the poll in about 5 seconds. There's a lot still coming through, actually, maybe 10 seconds. Okay, I'll end the poll now.
All right. Okay, so for the first question, what tolerance toxicity profile would you place him under? So there's a fairly even split between us. So 36% have voted for moderate and 32% have voted for very high. 25% have voted for moderate high. So I would have to concur with folks who voted for very high, just because Jason is actively using 1 to 2 grams of fentanyl per day. So you've got to realize that fentanyl is just this extraordinarily potent opiate. And if you're able to tolerate 1 to 2 grams of fentanyl on a daily basis, you certainly have extremely high tolerance towards opioids, such that like all the other non-synthetic opioid options would probably not be able to reach the mu opioid receptor occupancy that you're used to, just because fentanyl is that potent. So as we had seen in the previous toxicity and safety risk profiles, the fourth table on the very right, fentanyl use automatically puts you in that table. So in this case, Jason does have very high tolerance and low toxicity risk. So that's the profile that we put him under. Moving on to the next question, what OAT would you prefer? This is a really this was a I think this is quite interesting, the finding. So a lot of our folks have mentioned SROM plus MMT, methadone maintenance treatment. I would have 100% concurred with you, just because from our risk and toxicity tables, sorry, safety and toxicity tables, as well as our previous slides, I've mentioned repeatedly that combining SROM with methadone is an acceptable option for patients who are actively using fentanyl. However, if you remember, Jason experienced ADRs and intolerance to methadone. He experienced a lot of nausea as well as diaphoresis, and he discontinued therapy with methadone previously. So in such a situation, it is okay for us to just proceed with SROM alone. We wouldn't combine Suboxone either, just because he experienced more cravings, more withdrawals, and he's likely not going to be willing to trial Suboxone again. So SROM alone is probably going to be our therapeutic choice here. And finally, for the third question, what dose of SROM should we start for with Jason? I see that a lot of our folks have erred on the side of caution and started with just 100 milligrams. But once again, if we were to place Jason on the far end of our toxicity safety risk, where he's likely to have very high tolerance, low toxicity, starting at 300 milligrams is actually fairly appropriate. So as I said, fentanyl just has this extraordinary opioid receptor occupancy, potency. So 300 milligrams of KDN is actually a great place to start without this causing toxicity or without this causing overdose. Okay, so moving on to the next slide and moving on with our presentation. So inpatient monitored initiation and considerations for those of you who do work in an inpatient setting. In hospital settings, we often start with PRN, IR morphine as well. And we are doing IR immediate release morphine in an inpatient setting, just because we can monitor the patient. You have nursing, you have clinicians, you have the patient's own care team who can monitor the patient continuously. So using immediate release morphine is acceptable to manage cravings and withdrawal. So on day 2, we calculate 50% of day 1's total dose and give that as SROM. On day 3, we add 50% of prior PRNs to the SROM dose, and this is how we induct SROM therapy in an inpatient setting. Some key things to remember is that SROM beads can't go down a feeding tube and can cause PIC occlusions. So if your patient in an inpatient setting has an IV access, as this patient on the right in the photograph does, key things to remember is if they are unmonitored and if they, for some reason, try to inject those beads themselves, they can cause occlusion of the PIC line, which is like this long catheter that goes up your arm into one of the central veins. Or even more dangerous is that those beads can clump together and pass on into systemic circulation, leading to serious VTE events. And lastly, if your patients have a G tube, which is a gastric tube, or a nasogastric tube, an NG tube, like a dog hop, which goes through your nose for feeding purposes, for medication purposes, so on and so forth. So in these cases, these beads can clump together again, and they might not actually pass into the gastric lumen or your GI tract. And when you try to flush the tube with saline, all of these clumped beads might accidentally just get flushed down, and then you have a huge bead of just Cadian morphine, which is now getting released slowly into the systemic circulation, which can lead to toxicity. So unless and until you have a patent GI tract, you cannot use Cadian. Next slide, please. So transitioning between opioid agonist therapy. So if you were in a community setting, you might see prescriptions where patients come in with a prescription for both SROM and methadone, or SROM or Suboxone. So we're here to talk about that, as to how to actually see what's going on the prescription and figure out what's happening, what's appropriate, what's safe, and if any recommendations or changes are needed. So switching OAT should be guided by the patient's goals or clinical reasons like ongoing use, side effects, or poor retention, as Ivana had mentioned previously. SROM may be a good fit if methadone or buprenorphine haven't worked well for the patient. Next slide, please. So our first scenario is switching from methadone to SROM. So when switching from methadone, either cross taper or stop and start. We prefer cross taper just because it has less withdrawal. We certainly don't wash out methadone. We don't give methadone's 5 days half-life for it to get washed out, because that will definitely precipitate withdrawal and put the patient at risk of either experiencing withdrawal symptoms or using illicit unregulated opioids, which we obviously don't want. Cross taper minimizes withdrawal. We certainly don't want washout. Increase SROM every 1 to 2 days as guided by symptoms and adherence. And I've put a sample cross taper table to your right for your perusal. As you can see, day 0, only methadone, and by day 5, we have the patient only on SROM. Next slide, please. There might be cases where the patient wants to switch from SROM to methadone. And to switch the other way, we recommend cross taper. A cross tapering to reduce toxicity risk. A 10:1 or 12:1 SROM to methadone ratio is preferred. Adjust every 3 to 5 days, and we monitor closely for sedation or toxicity. Next slide, please. Switching from Suboxone to SROM, so the estimated ratio, so there's really not a lot of great pharmacokinetic data out there to suggest what exactly is the ratio, conversion ratio between SROM and Suboxone, just because Suboxone is a partial agonist, it's not a full agonist like SROM, morphine. Based on some anecdotal data, the ratio is estimated as 1:42 to 1:58, but because it's very anecdotal and quite a large range, it's reasonable to just use to establish a starting dose based on tolerance and toxicity profiles that I had discussed earlier. Microdosing, reduce the starting dose by 25 to 50% and starts from the next day after starting Suboxone. In this case, we are not waiting for Suboxone to get washed out. We're just starting the next day, because as you are aware, if you combine Suboxone, which is a partial agonist, with high doses of a full agonist, that's likely to lead to competitive antagonism, and that will lead to withdrawal symptoms getting precipitated. So that's why we wait. If Suboxone's last day is today, then we start from next day. Next slide, please. Switching from SROM to no, Suboxone, so this is also a case where you might experience this in the clinical setting. So usually we initiate Suboxone. So this switch does require the patient to enter withdrawal before starting Suboxone, typically 24 to 36 hours. Microdosing protocols, both rapid and gradual, do allow for overlap, minimizing withdrawal risk. So I have this table right next to you. So this is a sample table which delineates both gradual microdosing and rapid microdosing. Both of them are acceptable. And in this case, as you can see, we are cross tapering. We are not stopping SROM and starting Suboxone the next day, just because we are starting Suboxone at low doses, so the risk of competitive antagonism-based withdrawal symptoms is minimal. Next slide, please. So in a community setting, once again, missed doses are really important things to monitor for. So missed dose protocols mirror methadone somewhat. So 1 to 3 missed doses, you typically just resume usual dose. If carries are planned for that day, we don't give any carries. 4 missed doses, typically we would cut the dose in half or restart the titration altogether. That's between the patient, the clinician, and your recommendation. And 5 or missed doses, we restart the titration from scratch. And as a pharmacist, it's strongly recommended that you speak to your patient, address barriers to compliance, just so that we don't have to restart the patient, don't have to induct the patient again and again. So that's just setting up the patient for failure and the strong therapy for failure. So you play a really important role here in addressing what are the root causes of compliance, like barriers to compliance, what are the issues, and if you as a pharmacist can help that. Next slide, please. So take home dose criteria or carry criteria. So we follow methadone style carry criteria, which involves stable housing, safe storage, low diversion risk, etc. Um, the, just like you would have a contract in place for methadone carries, you can come up with a contract in place for your patient and you to sign for strong carries as well. Um, Typically, after 4 weeks of stability, you can begin with 3 non-consecutive carries. So, for example, um, Monday observe, Tuesday carry, Wednesday observe, Thursday carry, Friday observed, Saturday carry, and Sunday observed, or Saturday observed and Sunday carry. That's up to you. And once the patient has been stable on SROM therapy, same dose for up to 12 weeks. Up to 6 carries per week is reasonable. So you can bring the patient in on Monday and you can give him carries for the rest of the week. All carries should be in individual containers, individually labeled for that particular date. That's the recommendation. Next slide, please. So, pharmacy monitoring. As pharmacists, we ensure the patient ingests the dose properly, either swallowing capsules whole or mixing beads in liquid. We never give the patient just the beads from within the capsule in a plastic cup. The beads are static, and the plastic cup is also quite staticky, so the beads might remain stuck to the cup. The patient might not be able to swallow it. Also, there's a risk that the patient might chew the beads, which can lead to immediate toxicity because that IR/SR component that Ivana mentioned will be lost right away. Um, Never allow beads to be chewed or crushed. We also monitor sedation using PAWS scoring system and withdrawal using COW scoring system. Urine drug testing is something that you can entail if delegated by, let's say you have a provider within your pharmacy setup, or your pharmacy is in a clinic setting, then you can have the prescriber delegate urine testing to you, which I will not go into detail here for the sake of time. But MERA-5 guidelines as well as BCCSU do mention that in depth. And finally, if there are any barriers you like to compliance, patients not showing up, then it's your job to assess that and help the patient with that as well. Next slide, please. So this is the Passero opioid sedation scale. This kind of assesses if your opioids are dosed appropriately or heading towards the toxicity side of things. So A score of 3 to 4 is unacceptable and requires urgent intervention, dose reduction, or even naloxone in the case of somnolence. So, in your practice, community or inpatient, use this tool daily in both settings. I won't go into the depth of what each criteria is. Feel free to read the slide. This scale is also available online freely on various calculators. Next slide, please. And finally, we have the COWS clinical opioid withdrawal scores. So basically, this is a scale which tries to really quantify objectively various aspects, symptoms of opioid withdrawal. And so there's so many different factors and different scoring criteria. So I've added a link to MD Calc at the bottom. Just to summarize, a score of 13 to 24 is moderate, 25 is high, and this will tell us whether the patient is experiencing significant withdrawal symptoms or not. So next slide, please. Coming back to our Jason patient, as a pharmacist, let's say you implement a monitoring plan which involves assessing efficacy versus toxicity, and you encourage Jason to take home a naloxone kit. So I have a polling question for you now. So what titration schedule would you recommend to Jason's MD-NP, considering your assessment shows he's compliant and is grade 1 on POS and scores 20 to 30 on COWS? Okay, I'm glad to see that a majority of you picked 100 mg daily. So that is the correct response, just because once again, we classify Jason as very high tolerance, low risk of toxicity, and 100 mg daily titration is an acceptable modality. 200 mg daily is typically not acceptable. 200 mg every other day is acceptable. So great job, everyone. Thank you. Moving on to the next slide. Thank you. So stabilization and chronic therapy. So once stable, the goal is to maintain the lowest dose that controls symptoms, withdrawal symptoms. Longest studies are up to 36 weeks, but use longer than this is likely to be safe as well. And in practice, use longer than this is fairly common. Tapering follows the same principles as methadone and Suboxone. And once again, the goal here is to prevent withdrawal, avoid, like, help your patient avoid the use of unregulated unprescribed supply of opiates, which can be quite dangerous, and work with the patient to slowly taper these off when the patient is willing and agreeable. Next slide, please. So I've attached a sample from RX, which is reproduced from the Metafy guidelines as is. So the key elements, once again, is total daily dose, formulation, observed or carried, which is mentioned in the comments below, and dispensing instructions. So feel free to review this your convenience. And next slide, please. I know we are running really short of time, so I'll quickly go through this. Pharmacists are critical to safe success of SROM. So in a community setting, for example, pharmacists must ensure proper administration when you're observing the patient taking his dose. Monitor sedation, withdrawal, and adherence as with the tools that we just discussed. Assess for potential drug interactions, both kinetic and dynamic. Collaborate with prescribers in recommending dose adjustments based on your assessment of POS, COWS, sedation, withdrawal, missed doses, so on and so forth. And finally, support patient education. Address barriers to compliance and provide teaching on identifying signs of toxicity, withdrawal, and when to seek help. Provide naloxone kits and educate your patient. Next slide, please. So we come back to our Jason patient. In this scenario, Jason collapses while at your pharmacy, no pulse, no breathing. What are the first steps that you take? Would you call 911? Would you start CPR? Would you get naloxone and give intranasal ×1? Or would you get an AED device and attach to the patient? AED is automated defibrillator. Okay, so the results are in, and most of you recommend getting naloxone and giving it intranasal ×1, which is great. Which is absolutely fantastic. So that is what you should do. If ideally you have somebody who's working with you in the pharmacy, or somebody who's available, who can go fetch the naloxone for you while you're administering CPR, just so that there's no break in CPR. However, there is evidence out there that suggests that patients who receive naloxone during an out of hospital arrest, and when they were brought into the emergency room, or when EMS started doing CPR, they achieved better rates of ROSC, return of spontaneous rhythm circulation. So naloxone intranasally is a great option. Also, even if there is no circulation, intranasal naloxone doesn't have to reach your lungs to get absorbed. It gets absorbed through the nasal mucosa. So there's also evidence of there's in cases of circulatory collapse, intranasal naloxone might be a little bit more efficacious than IN naloxone actually. So intranasal naloxone is safe to give during these situations. Um, and finally, we have our question, if so what is it that you do in case if Jason wants to go home, or Jason wants to go leave your pharmacy? So just because of the kinetics of strom, we know that it's slow release. We also don't know what Jason has used recently to have gone into overdose. So in these situations, it's not safe for him to just leave, because naloxone's half-life is really short, 30 minutes of benefit, that's what all you get. So after 30 minutes, he's potentially likely to go into an overdose situation again. So it's very important, and like it's very, very important that he is seen in an emergency setting. He's admitted so that he can be monitored. If we need to run a naloxone drip, we do that, and we titrate that to Jason's symptoms. But we keep him in a monitored setting until we are sure that there's no more supply of opioids available in his system. Alrighty, moving on to our last slide. Next slide, Kathy. Sorry, the last one.
Yep, sorry, I have to close all the poll stuff first. Give me a second. Yeah, there we go. Yeah.
Okay, so finally, SROM, just to wrap up, SROM is a valid opioid agonist therapy alongside methadone and Suboxone. It may even improve satisfaction and reduce cravings over both of the current existing options. Dosing must be patient specific, and you, as a pharmacist, whether you're inpatient or in a community setting, you play a central role in safe implementation of SROM therapy for your patients. Thank you. I'll just
Thank
bring
you so much. Thank you so much.
the
Oh,
screen.
yeah, Ivana and Aviral, for your very interesting presentation. I think there are a couple of questions here that we can there were a couple, and I want to give everybody an opportunity. If you do have questions, please use the Q&A box and enter them in that box. The first question is, what is the maximum dose of SROM, which I think you answered, but maybe people need to hear it again in terms of that rationale.
Repetition is always good. So certainly
Yeah.
there is no ceiling effect. The literature does suggest a dose of 1200, but in practice we have seen over 12,000.
2800.
Is it?
Yeah, so published data, there's data published out there that recommends, that has seen patients take up to like 2000 milligrams of Cadian. I personally have seen up to 2800 milligrams, and that patient was perfectly fine. You would not be able to tell that this patient is taking 2800 milligrams of morphine on a daily basis unless you had their chart open. But yes, it's safe, and it's effective when used appropriately. So there's no ceiling effect.
Thank you. There's a second question here. Is there data to support adding SROM to patients already on high doses of methadone to be continued together long term?
So I'd like to take this question, Ivana. So really, the first question you should ask yourself is, why are we considering SROM if the patient's already on high doses of methadone? Are you concerned about things like QTC risk? We know that like Once you get up to the 90 milligram marks of methadone on a daily basis, the QTC prolongation risk becomes quite significant. You can employ strategies like splitting up the dose in BID setting instead of just giving once daily methadone. But really, if those toxic effects are visible and you see that your patient who's on high doses of methadone, his QTC is slowly edging up, he's now above the 500 millisecond mark, at that point, the goal should be to switch over to another therapy, which can be SROM, instead of just adding SROM to it. So once again, to answer your question, why are we adding to methadone? Ideally, if there's a risk of toxicity, if the patient's not compliant, if there's ADRs, then we switch over instead of adding to SROM. Adding to methadone. I hope that answers your question. Okay.
Yep. We have two more questions, and I hope that you can stay a little bit longer to answer these questions. And thank you to the audience so far who are able to stay. I've seen Dilaudid name brand instead of generic requested. Why?
Interesting question. So sometimes your patients will have a preference for one particular brand of drug. I've actually, so when I used to work in community, I saw this very, very commonly with Percocet. Everybody wants Percocet with that tech on it. So sometimes they're also visibly able to identify which is what, and that really drives their choices and their preferences. They think that one works better than the other. We know that in Canada, all biosimilars, so all bioequivalent drugs, all generics, are stringently required to meet a certain criteria where they're bioequivalent to the brand name within a certain margin of error. So it's our job then to educate them that, hey, listen, this is cheaper, or this is available, your preferred drug is on back order, your preferred brand is on back order. So it's perfectly safe to use this. There's no reason for us to just switch to another therapy altogether. So yeah, I mean, if you do see that, that's very much patient driven. That's a patient perspective. There's no pharmaceutical or scientific basis to justify that. So it's then going to be your job to advocate this information to your patient.
Thank you. This next question is interesting. Are your patients provided cognitive behavioral therapy?
So I'll just use an example of a patient I have right now who's been admitted with a cannabis-induced psychosis, background of ADHD and opioid use disorder. So he's actually followed by the substance use service as well as psychospiritual care. And certainly there is some cognitive therapy being provided by the nurse practitioner from our psychiatry team as well. That's We have all three services, luckily,
Right.
in our center. So it can be a combination of different allied health professionals that are providing that help. In the ABI and TBI population as well, we have a lot of involvement from the psychospiritual care as well as nurse practitioners and nurses from psychiatry and SUS,
Right.
substance use service.
And just to add to what Ivana said, so CBT is definitely, there's a lot of evidence that it does support opioid use disorder. In my practice, what I found is a lot of our patients who are suffering from opioid use disorder, getting them in to actually get through CBT is the bigger challenge. So I've had a lot of success with patients who've been stabilized on therapy, who have not used unprescribed opiate supply recently, and who find that their cravings are manageable, their lifestyle is stable. I find that getting them into CBT is a lot more easier than than during the initial induction phases where they're just trying out, they're trying to see if something works for them. But yeah, there's definitely a big role.
And just one more question here. If the patient has severe asthma, which approach is better? This might have been in relation to the question that was asked earlier, that you were mentioning something earlier. I don't know if you have enough information there to answer this question.
Right, because we're monitoring for respiratory depression.
Right.
Oh, is that there? Yeah.
Assuming that's why the question. Suboxone?
So yeah, in terms of toxicity, we know that Suboxone has a ceiling effect, not in terms of its like benefit as a mu opioid partial agonist, but it has a ceiling effect when it comes to toxicity. So if you're concerned that a patient who has asthma or any other respiratory difficulties, like higher doses of full agonists like Cadian or methadone might worsen, like depress their respiratory drive and increase hypoxia, worsen their respiratory circulatory status, then Suboxone is definitely a better choice. However, monitoring the patient is also key. If the patient tried Suboxone does not like it, uh, you have to realize that Cadian is still a better option than unregulated, unprescribed supply of full agonists such as fentanyl, which are extremely potent, which are likely to severely depress the respiratory drive. So, risk versus benefits, yes. It is a contraindication. However, it might still work in the patient's favor if you were to look at the alternative, which is an unregulated supply of opioids.
Yeah, just like with renal insufficiency or hepatic dysfunction, it just requires close monitoring. By all means, if somebody has severe asthma and bronchospasm, you might want to hold off on Cadian being your number one choice. But if that's not the case, start low, go slow, and monitor the patient would be the way to go if they really truly prefer to go with a full agonist.
Okay, thank you so much. I think there's one more question here. We have a minute left. If you are okay with answering this one, I think this person also put it in the chat too. So if a patient missed 3 doses, can we still dispense or stop and contact the doctor?
Great question. So up to 3 doses is acceptable. I wouldn't give the patient any carries if he was supposed to get carries today. But missing more than 3 doses, which is if he's missed fourth dose, that's when I would not dispense Cadian. That's when I would go back to the prescriber, reach out to the prescriber, and recommend that the dose be split in half, just because we cannot support, like the patient has missed 4 doses and is likely needs he's lost that tolerance quite a bit. Um, a lot of cases you might not be able to reach out to the prescriber. Maybe it's after hours. Feel free to recommend that the patient visit the nearest ED room or the nearest RAM clinic if they're still open, and have the therapy reassessed by them. You can draft a letter. You can give that to the patient to take to the ED room. You can attach a copy of the prescription profile, history, what's been taken, what's been missed, just so that it's easier for the patient to be seen and it's easier for the clinician in the ED room to actually help the patient.
Great. And I know we're still getting lots of chats and Q&A, but I want to be mindful of your time. But so thank you so much for taking the time to educate us on this really interesting topic. And I think that a lot of people have taken away some really good information that hopefully they can take to their practice, especially since this is an area that maybe a lot of community pharmacists aren't as familiar with. So I do appreciate both of your time to educate us on this really, really important topic and another avenue, I guess, to support patients who need this type of treatment. And for there is a question about whether this is being posted. We do include this as part of our addictions and opioid therapy module series. I can put that link in here if you want to check it later. I'm not being able to post it right away, so but it will be available as part of our opioid and education thing around opioid and addictions and opioid agonist therapy education module. It's a bit of a mouthful, but I'll put the link in here if you want to check that out. It'll still be several days before this is posted there. And thanks again, everybody, and take care.
Thank
Bye.
you, everyone.
Thank you,
Kathy.
everyone, for joining us today. Thank you, Kathy.
Thank you.